And thank you again for making it and taking time out to ensure your success, which is most important. I know it's a tough time of year to study because it's the end of the year. Everybody's getting ready for festivities and having a good time. And I'm in my holiday mood, got my holiday background going. So I hope everyone can still just focus in on your priority to pass NCLEX, but you also want to take some time out to enjoy time with family. All right, so motivation. We'll start out with some motivation. Be like an eagle, fly high above those self-imposed limitations. Don't limit yourself to any thoughts that may impose on you to make you think like you can't move forward or you can't pass the test. Stay positive. NCLEX is a tough exam. It is a selfish exam, and it is a serious exam because again they're testing entry level nurses to see if we're going to be safe. So, safety is the biggest priority on NCLEX. Are you going to be safe as a nurse? And they want to make sure you're safe to practice nursing and that you're going to be safe for the public. And it's the public's way of knowing that, yes, we've studied, we've gone through school, we are officially graduated. We didn't have that, the issue that was going on in Florida where people were getting licensed and things. And so it's just a way that they can test to make sure we're safe or we should be safe. So take it seriously, put your all into it. You can do it, but don't limit yourself. Don't get discouraged, even if you're getting questions incorrect. It's all a learning process. Every day is progress. So I was hoping we was going to have a speaker tonight. This young lady, she had to work. She said today, so she wasn't able to make it. Her initial is ND, but we started studying on Wyzant. Oh, I forgot to pull up her score report. I was thinking I'll pull it up. I believe it was September for her. Um, and she took her exam on the 7th. So I just clipped this from, let's see, she did her pre-test September, 9/18, September 18th. And on that day, usually when you take your exam, I wish you blessings and may everything go well. So that was that day before, which was the Thursday. And oh, I gotta change my pen. So that was on that Thursday. And then that today was yesterday, 12/8 was when she messaged me. So she must have did a quick result because she said, "Hey, I passed. I got my results." But she studied for NCLEX RN, took her NCLEX RN exam. Um, can't remember how many times. I know she was a repeat test taker, but I'm not sure how many times. But maybe she can join us on another day that she's not working. All right. So today's agenda, we're going to review physiological adaptation per the NCSBN test plan. We'll just do a quick review of what that means, and then we'll look at three questions. The first question I'm going to just have you answer and see if anyone can get it correct. It's a tough question. It had me stumped for a minute. I had to go through those testing strategies and see, how can I reason through the answer. And if anyone can get the correct answer, we're doing some prizes and giveaways. So a way to bless people over the holidays. If anyone can answer it, even if we have multiple people who can answer it, you'll get a free lesson. Then we'll look at prioritize hypothesis after we do three questions. So just the first question you'll do and answer, and then we'll do two more questions, and then we'll do prioritize hypothesis, which is an NGN skill. It's part of the new portion of the next gen. And then we'll have one more winner, a door prize. I'll look to see who was the first person to register, and they will also get a free lesson. All right, so that's our agenda. Next Saturday, we'll do safety and infection control and generate solutions. So that'll be on the 16th. All right, physiological adaptation. So for the NCLEX RN exam, it is one of the top three portions of the pie. So it's management, then pharm, then physiological adaptation. So it's 14%. It's the meat and potatoes of nursing. It really is. It's med surge. It does frustrate people a lot because it's what we do as a nurse. We're figuring out what's wrong with the patient, what I'm going to have to do for them as I'm taking care of them during the day or night. So it is the meat and potatoes. It's the reason you go in and you get your report. You want to know who's the patient, What's wrong with them, and what do I need to do for them today? What's my hypothesis? What am I thinking about? What's going to be their problem? The problems that I have to fix. The client needs, patient needs. All right, so it is on average 11 to 17% of the exam. All right, and then for this category, the RN is managing and providing care for clients. Basically, it's the acute problems, the chronic problems, the life-threatening physical conditions. Right, so it can be any of those things. I think tonight some of our questions are going to deal with telemetry, managing the care of a client with telemetry. Can't remember what the other ones are, but we'll see as we go along. All right, for the LPN exam, coordinated care was top, then farm and safety are actually tied, and that's really true. When I was at LPN, I was on the med cart passing meds and keeping my patients safe and preventing the spread of infections, or assessing if a patient may have had an infection. Those are the top three. So physiological doesn't weigh as heavy as safety, but it's 10%. It's still more than health promotion and maintenance. So it's 10%, a little bit less percentage. And on average, it's 7 to 13%. Okay, same thing for the LPN. You're participating in providing care for clients with acute, chronic, life-threatening physical conditions. So it can be your trach care, your cardiac monitor, recognize and report basic abnormalities on the heart monitor, the cardiac monitor strip, pacing device, ostomy care, ventilator, acute or chronic illness, identify signs and symptoms related to it. All right, so for this first question, we're going to look at, I'm just going to kind of let you read through it, but think about your test taking strategies. And if I had to add anything onto this other than like the priority and closed-ended words, comparable and alike, umbrella options, choose a nursing intervention over medical. Um, think of the concept in the question. Is it similar to the option? The other thing I would keep in mind is nursing actions. Because physiological adaptation is what you're going to do for the patient. Sometimes they want you to prioritize it. What's next? What's first? Put the steps in order. What you're going to do. So nursing actions. There's two things that you are going to think about. Um, and then I'll also keep in mind priority. What's most important for the patient. All right. And sometimes the subject helps. I don't think we'll have any subject base this time, but that does help. All right, so we're ready for the prize. I'm going to set a timer. So we're going to look at this question, and I'm going to set a timer for 2 minutes. So if you had 2 minutes per question on a 5-hour exam, you could do 150 at exactly 5 hours. There will be some questions that won't take you 2 minutes. So you may do a minute and a half. It's safe to say a minute and a half per question, but I'm going to set the timer for 2 minutes. All right, is everybody ready? Ready to start? Okay. All right, if we're ready, I'm gonna go ahead and start my timer, and just take your time, read through it. When you think you have eliminated all your choices and you're, confident that this is what you think the answer is, just put that in the chat. All right, ready? We're gonna start. All right, the timer is going. We got 2 minutes. This should be just uncontrolled AFib. That was a typo. right, we're down to 1 more minute, 59 seconds and counting. All right, we're down to 20 seconds. 20 seconds. All right, 5 seconds. 4, 3, 2, and 1. All right, very good. Very good. All right, so let's see. This was tough. This was a tough one. All right, so I don't know if you want to just break it down. Maybe we'll just see what the answer is. We'll go with the answer and then we'll just break it down. So if you answered A, you are correct. If you answered A, you are deserving of an extra tutor session. Getting tongue tied. So if you answered A, good job. Very good job. Excellent work. All right, so to break this question down, you want to focus first on your case event. And our case event was the patient had history. So it's a history of uncontrolled AFib. So not controlled AFib. All right, so they have a dysrhythmia. Atrial fib, the QRS is going to look narrow. The P waves, you can't really tell where the P waves are. They're going to look like little scribbles and they look like they're all over the place. So I probably should have put up a rhythm. I'll probably add that to the notes just so you can see. So atrial fib looks like it's kind of all over the place. The P waves are not really defined and it's going to be irregular. All right, so the nurse notes the patient's heart rate suddenly, just all of a sudden, it goes up from 90, jumps up to 150 on the central monitor. Which action should the nurse take? So several ways you can think about how to prioritize. What I would do first for a lot of questions that ask for nursing action is what would I do? I would just try to answer that in my mind really briefly. For anybody with a dysrhythmia and they have a change, I want to know, are they stable or unstable? So if I was thinking about that without looking at the questions, how would I know a patient is stable versus unstable? Well, you go and check them, you look at them. You might need to get more vital signs. So the answer I'd like for it to say is check their vital signs, check their blood pressure, see how the patient is tolerating that 150, because that may guide me to know what to do next. So an action may need to be more assessment to guide you to what you should do next. All right, so nursing actions. Number one are going to fix the problem, or what can I do to help the patient, or do I have enough information to know what the problem is or how to fix the problem. Okay. And then the second thing is, how can I keep my patient safe, or is there a safety issue? All right, so several things you want to start with eliminating is, I don't want to choose something that's not nursing. So option C was not a nursing thing to really do. I mean, we do prepare our patients for transfer, but that probably wouldn't be the next thing to do. What action will we take? That's going to be based upon, is that patient stable or unstable? Do they need to go to ICU? Maybe we can fix them here before transferring. The doctors are probably going to make that decision. So that was a little more beyond, a little bit beyond nursing. So that was a good one to get rid of. All right, so the next thing is D. If we look at D, let's see, review the history. Well, let's look at B. B says have the telemetry tech let the nurse know of any changes. So the first thing you want to think about there is, can you let that nurse know? If you're not the nurse for the patient, is that something you can go and do? Go check on the patient or go let that nurse know they're having problems? Or do you have to let the telemetry nurse know, telemetry tech know? Now that is a delegation. You could delegate it, but remember on NCLEX, Usually when they're asking what's your action, you're not going to be delegating. They'll set that aside for delegation questions. So we don't want to give and it's kind of an important task to someone else. Give a task to someone else that we could do ourselves. Okay, and so especially if it's the LPN and you need to let the nurse know that there's a change in the patient condition, as a LPN, you can let the RN know. Same thing if I was an RN, just seeing that on a monitor, I can go let the nurse who has that patient know that they're having changes. So that's a good one to get rid of, B. All right, so they don't really, those two, don't really do anything for safety, doesn't really help the patient or fix the problem. When you look at A is not really a fixing the problem action, but when you compare that to D is kind of in the past, reviewing their monitor history for the rhythm change. Well, we know they're in AFib, and that's not a bad idea to look back. When did they go into AFib? Well, they suddenly went in AFib at 8:30 or whatever time. That's not a bad idea, and it's probably some information we would give to the physician, but what am I going to do with that information? Probably nothing. I mean, yeah, it happened at 8:30. But when you look at A and what threw us off, if you were thinking, well, we don't defibrillate, and this is where my thought was going, we don't defibrillate AFib. We defib. However, this patient does need to be on a monitor. We need to do like blood pressure. We need to put them on a bedside monitor in case they start crashing on us. And then the code card is already in there. Would this be different from on the floor? I feel like it would. And remember, NCLEX questions are not always what we see in real life. They're kind of by the book based upon what you have. If you have the choice to do these things, what would you do? And that may be how you want to ask yourself, what would I do if this is the only choice I have in life to do, only choices I have in life, what would be best for me to do to help this patient? And it would be better to just put them on a monitor. That way you got supplies, you got medicine there. If they do cold, if they do pass out, the cold card is in there. We probably we won't be defibrillating AFib, but if we need to, if they go pulseless or something, we can put pads on them and we can continue to monitor them. The answer I wanted to have was looking for was check vitals. Go see them. Go look at the patient and check their blood pressure. All right, very good job. So between D and A, um, there's not much we can do with the information of when did they go into when did they go into AFib with RVR? When did that heart rate go up to 150? All right, very good. So if you got that one, A, I see a couple people had put A. Very good job. Um, it is a life-threatening dysrhythmia. AFib is not a deadly dysrhythmia. You can live with AFib, but if they're in 150, their heart rate's 150 for a long length of time, it's going to wear out, and that's where they get into trouble. It also puts them at risk for blood clots. All right, so let's see. Changes detected. The patient should be transitioned to a bedside monitor. I just want a Dynamap or something in the room. If we're not in the ICU, put something in there where I could run blood pressures every few minutes until we can get medicine to get this heart rate down. So we want to monitor and provides monitoring and intervention is needed because the cart's going to have meds on there. All right. So we shouldn't delegate something to someone for an unstable patient. That was a good explanation of why not just tell somebody else to do it. They're unstable. All right. And then they have a history of AFib. We may not have to transfer them to a higher level of care because it is in their history. We just need to get their rate better controlled. Right, so it would not be the priority to review their cardiac history. All right, so we got two winners. Let me just take a screenshot of that so I know what answers you have. Very good. All right, so we talked about fixing the problems priority. Priority is also when you're looking at nursing actions, and if you get down to two, reason out one that probably is not the priority. Just focus on the now. So if you did get down to possible choice of A or D, D was a good one to get rid of because that's focusing on the past. Well, what can I do for him right now? Put him on the monitor. All right, so that's one way to reason out. Focus on the now. Never ask someone else to do what you can do in the NCLEX world. They'll ask you delegation questions. All right, very good. So with this one you have to put in order. These are the next two questions are some commonly missed. They're probably the top missed questions for physiological adaptation that I see. And you want to put in order, chronological order, what to do for this patient. So their physiological problem is they got a penetrating chest wound. And there's a rush of air coming out through the trauma site. So they either got stabbed in the chest or something impaled them or rammed them in the chest, and now air is coming out. All right, so what would be the first thing you want to do? So remember, it's an intervention. Interventions are nursing actions. So the first thing that would fix the problem or help this patient or keep them safe, what would be first? Should we do oxygen, put a dressing, blood gas, or pain? All right, very good. Awesome. So if you said two should actually be first. Very good. Two is going to fix the problem. Now, it doesn't really fix the underlying problem that they got this hole in their chest and they're probably going to develop or are developing a pneumo because air is now rushing in through the trauma site. But with the first thing you want to do is do something that helps the patient. So think about your problem. What is the problem? They got stabbed or something went in their chest. I need to cover that site. That's going to prevent more air from rushing in, which is going to create more problems. The more air you get in your chest, the greater the pneumo. But we also want to cover it so that air doesn't go in, but air can come out. So maybe like a 3-window dressing. All right, so that fixes the problem temporarily. It kind of prevents it from getting worse. All right, what's next? I see some 4s are being 2-4. What would be next? All right, we got 1. Very good. So oxygen. So when you look at these, you have one says, check the blood gas. One says put them on oxygen. They're both dealing with airway, breathing, and circulation. However, the next priority is what else fixes the problem or helps this patient? ABC, airway and breathing, get them on some oxygen because now their lung, their chest area is compromised. And what will the ultimate goal for this patient is to get a chest tube put in. So you're going to begin that setup, get things ready for the doctor to put in the chest tube. All right, good job. All right, then the next thing we're going to do between 3 and 4, you're right, 3 and then 4 should go next. When you look at monitor blood gases, this is also a way to prioritize. Again, you go back to your prioritization, airway, breathing, and circulation. And remember Maslow's hierarchy of needs. Our interventions can be guided by what is the patient's need? What do they need? They need all these things. Well, how do I know what comes first? Prioritize based upon Maslow's. A patient's need or their problem is a part of Maslow's. So first, we're taking care of physical needs. The top physical needs are airway, breathing, and circulation, putting the oxygen on, getting the chest tube. All right, next, you want to go ahead and get the ABG, see where their oxygen is. What is their O2, their PaO2? What is their PCL2? All right, and see if they're going into respiratory failure. Do we need to go ahead and intubate this patient? All right, so that's next. When you look at pain as far as a physical need, pain comes after airway, breathing, and circulation. A monitor just means you're going to assess their blood gas. Whether you interpret it as being you're going to obtain it, somewhere they had to obtain it in order for us to be able to go back and assess it and look at it and see what is it, is it good, is it bad, are they deteriorating? You want to get that before you medicate them, because what if they do need to, we don't want to put a lot of what ifs in it, but what would I want to know before I give pain medicine? I want to know vitals. I want to know how is their blood gas before I medicate them with pain. Medicate them with pain medicine. All right, very good. So great job on that one. For the pneumo, this is just a little clip of some things, some interventions. Collaborative management. Oxygen per nasal cannula, 2 to 5 liters. Position them from optimal ventilation. How would we want to sit someone up for who's having trouble breathing? We want them in semi-Fowler's or a Fowler's position, sitting up. And their good lung, you want down or back. So either just straight up is best. But if we had to do some turning, then if the bad lung was on the left, I would want their good lung down, because you want them to aerate the bad lung by having it up. So good lung is down. We do want to close the open sucking chest wound with gauze dressing. You want it taped on 3 sides so that air can escape during expiration. So he inhales, but when he exhales, that air can come out, so it's not creating a further pneumo. Prepare for that chest tube. Now, analgesics, they're going to be in pain, but they're going to be in doses adequate to allow the patient to cough, deep breathe as indicated. So I would want to know what, and they didn't mention ABG in here, but according to Maslow's, we want to know that ABG result first. All right. This question is one that, according to my analytics, no one ever gets this question right. Off the surface, it has 0 results. It has 0 results. No one has gotten this one right, and maybe probably with review, um, but no one's gotten it right, even with reviewing it themselves. So read through this one, and again, we are looking at priority of care. All right, and then this is the time proximity prior to administering the IV antibiotic that's ordered. What would be the priority of care for this client? All right, so priority of care, the first thing you're going to do, but it's the first thing you're going to do prior to giving this antibiotic. It's an IV antibiotic. All right. Should we check the site for infiltration? Is that a good thing to do first, or should we eliminate that? Any thoughts on option 1?
We should eliminate it.
Okay. So possibly eliminate. All right. So we got some yes to get rid of. We got some keep it. All right. So we're kind of half and half on that. All right. So we'll come back to that one. We'll leave it. Check the IV site for infiltration. Now, what you want to think about first, if I'm trying to do order, because this is kind of an order step, because you're doing a procedure. The procedure is you got to give this patient an antibiotic. What would be your step? So you want to think about that in mind. I'm gathering my supplies. It's an IV. I'm hooking the IV up in the pump. I'm looking at my patient. Where is their IV? Would I want to check that IV before I hook it up? So that's what you want to think of. Is that a step that comes before you give the antibiotic? So yeah, we got a lot of keep it's. So that is a step you want to do before. So I wouldn't eliminate it right away. Keep it and hang on to it. All right, let's look at 2. Should you do a complete physical assessment prior to giving an IV antibiotic? Now, that's for anybody. Anytime you're giving an antibiotic, is that important that you do a complete physical assessment? Complete means head to toe, nook and cranny, neuro, everything. Are you doing a complete physical assessment? Is it necessary? Is it a necessary part of the procedure in order to give an antibiotic? Okay, we've got some no's. All right, very good. All right. So this one, although at some point, yes, I want a complete physical assessment. If I didn't do one at the beginning of my shift and didn't get to see the patient, then I would do that, but is it necessary for the subject? Remember, the subject is, we got to give this patient an antibiotic. Is that something you need to do prior? And another way to think about that is, does your physical assessment make a difference on whether or not you're going to give the antibiotic? If he's in pain, am I not going to give that antibiotic? If my physical assessment is his blood pressure's up a little bit, am I not going to give that antibiotic? Or is it going to make a difference whether I give it or not? Does he still need the antibiotic? So, no matter what your physical assessment is going to be, unless you walk in the room and there is something like emergency going on, it's not really necessary to do a complete physical assessment, head to toe, in order to give him this antibiotic. All right, very good. So 2 we're going to get rid of. Some are saying that 3 may be the answer. Um, so with 3, should we check vitals? Check vital signs prior to giving your IV antibiotic. And you want to think about that in the same way. Is it necessary for me to have vitals before the antibiotic? What part of that is, um, what part of that assessment would make a difference in whether or not you're going to give the antibiotic? Should you do that prior? All right, this is where it gets tricky. So what I noticed, we got 3 assessment. Well, all of these are assessments. Checking, a complete physical assessment. We're going to check vitals, evaluate symptoms. Evaluate is still an assessment word. So we really need to pinpoint which assessment makes a difference in the procedure. The procedure is administering the antibiotic. All right, which assessment? All right, so priority. Some are saying priority may be 1. Blood pressure and heart rate. All right, so if his blood pressure is okay, or if it's low or high, does that make a difference of whether or not you are going to administer that antibiotic? Does that tell you, if his blood pressure isn't quite where you want it to be, does that tell you I can't give that antibiotic? Is the antibiotic part of that assessment for blood pressure? Or is it just something that's treating infection? That's what you want to think of. Is that assessment necessary? All right, very good. So checking his vitals, a lot of people are saying no. Checking the vitals is really not a part of your assessment, something you need to do prior to giving an IV antibiotic. But you're right. When I'm doing it, when I'm going into the room, there's certain things I'm going to check. But if I'm giving a blood pressure medicine, I do want to have that blood pressure. If I'm giving a med that's going to affect his heart rate, I want to know what his heart rate is before I give it. But with antibiotic, it's different. We're not treating a blood pressure. We're not treating a heart rate. And 9 times out of 10, antibiotics are not going to affect those parts of the vitals. It's probably not going to affect anything but maybe a temperature, maybe the fever will start going down. That's not going to happen immediately. So no matter what his temp is, no matter what their heart rate is, no matter what their blood pressure is, unless there's a medical emergency, like patient's not alive or something, you're still going to give that antibiotic because you're treating the infection. The infection is going to be there regardless of what his vitals are. So you really want to get rid of things that would not be done first. If you see something that's, maybe they put something in there that should be done after, and you want to get rid of answers that don't relate to the subject. It doesn't, like, does it make a difference in what I get in my assessment? Does that play a part on whether or not I should hold his antibiotic? So vital signs are going to be more so for your cardiovascular drugs, the meds that affect, airway, breathing, or circulation. Antibiotics just doesn't really affect A, B, and C. They treat infection. All right, so you may have thought about doing 4. Checking allergies is a priority. Evaluate symptoms. Now, I would want to check allergies prior, so I got to read this one carefully. Evaluate symptoms of an allergic reaction. Notice they say you're checking not the allergies that the patient have. They're saying you're checking for symptoms of an allergic reaction. When would he have an allergic reaction? Would he have that before he gets the antibiotic or after? Is that something you would check before or after? Yes, definitely after. You'd go back and assess and see, did they tolerate that antibiotic okay? And did they start itching and pruritus and urticaria? Did they have hives after? Do they have any other problems that could be a symptom of an allergic reaction? Very good. So this is something you should do after. So careful reading, because a lot of us would probably say, yeah, before I give an antibiotic, I would. That is something I would definitely do because that does make a difference. If the doctor ordered penicillin and they're allergic to penicillin, I gotta say, whoa, wait. I go and ask the patient, you said you're allergic to penicillin. Let me stop and let me go and check and make sure that we got the right order because this is not adding up. And so you're the first person to prevent an error from happening, from it getting to the patient. We're the ones that bring things to the patient, so we're like that second last check before it gets there. So this is a good thing to do before, but they're saying symptoms of a reaction, and that's after. So the time proximity was not right. All right, very good. So if you're saying one, if you thought one might have been, I know in the beginning it sounds like it could be check the vitals or do an assessment, but between one, two, and three, four was a good one to probably get rid of first because that's something you would do after. One, two, and three seems like something you would do first, a priority of care. Then you go back to your facts. The facts are they're getting an IV antibiotic. Do I need a physical assessment before I give an antibiotic? Do I need vital signs? Not necessarily. I mean, they're good things to do, but there again, what are you going to do with that information in relationship to giving the antibiotic? However, with option one, if you check the IV and it's bad and it's leaking, now what happens? You can't give that antibiotic. But if you flush the IV, it flushes fine. Patient says, "Yeah, it doesn't hurt. It's fine." Then now you can further hook up your tubing and prime it and connect it to the patient, set your pump, and they can get their medicine. So you're looking for what really makes a difference. What's the priority here before you carry out this procedure? All right, very good. That was a little tricky, I know. All right, so allergies you check after they have an allergic reaction. Yes, because they asked for prior. That's very true. So yeah, that last one should be something we'll do after. So for any IV site, any IV medication, either even during the medication administration, I might go back and check on them and make sure it's not hurting. Because just because you check before you start it, problems can happen during the infusion. The IV can infiltrate when it's running. It might have started out fine and then it goes bad. So you want to go back and check, make sure there's not blood outside, it's not bleeding or leaking, it's not seeping medication into the tissues. Extravasation is when there's a vesicant, something that can destroy the tissue, um, the surrounding tissue. That's a vesicant. Excuse me. Phlebitis is inflammation of the vein. Then you might even have a local site infection where there was contamination of the site or nerve injury. You usually don't see too much of nerve injury for peripheral IV, but those are some examples. So something that could damage the tissue, it just ate into it. Chemotherapy is, yes, it can definitely necrose the skin. That's why most chemotherapy is given through a central line, a PICC line, or a port. They usually have a port. Phlebitis, it swells up, inflamed. You see red streaks. And these three are probably the most common. Infiltration, fluid is leaking out outside the vein, and that can cause swelling.
Sorry, I didn't mean to interrupt. So the answer was four or
So yeah, let's go back. So our answer was option one. So because we're looking for something that's priority of care for the patient, something that we're going to do first prior to giving the IV antibiotic. So we have to think about in that step, what would I be doing before I administer this medicine to the patient? So you want to check their IV, check and make sure it's not infiltrated, check and make sure it's not leaking, that it's a good IV, it hasn't came out of the vein. And if it's a bad IV, now you have to stop and not infuse that antibiotic, but get another IV site. For, although it sounds like it's something you're going to do before, when you read it carefully, it says evaluate the symptoms of an allergic reaction. In order for me to check for symptoms of a reaction, there's something that the patient got that has caused that reaction. For instance, a blood transfusion. Once you start infusing the blood, they can have a reaction. So the reaction happens after they get the blood or the medicine. Same thing for antibiotic. After they get the antibiotic, they can start having allergic reaction. So during that process or after, that's when you're going to check for that. So 4 is something you would do after. So the better answers were probably 1, 2, or 3. But how to reason out is you want to look at which assessment would you do first makes a difference in how you carry out that procedure or whatever it is that you needed to do, whatever nursing intervention it was. In this case, it was giving the IV antibiotic. All right, very good. That was a good question. Harley, that was probably a good one to even put for, if you get that one right, um, to give a free lesson, because it's still 0 on my list. It says 0 out of 20 something people or something like that. No one gets it right. All right, so we're down to the last one, last question. Yep, the answer was 1. That was it. Yep, the answer was 1. Yep, check the IV site for infiltration. That's it. All right. And that's important when you think about you're gathering your supplies and then you want to get to the bedside. The next thing you would be doing is checking the IV. I got your antibiotic. I've got to, hook it up. A complete assessment can be done anytime. I could do that in the beginning of my shift. I want to do it early, but it doesn't have to be done before I give an antibiotic. Vital signs do not have to be done before I give an antibiotic. If we're doing vitals every 4 hours on a floor, 8 and 12, his antibiotic might be due at 10. I don't necessarily have to get vital signs at 10 just to give that antibiotic. Now, if I was given a blood pressure medicine, yes, I may not want to go by the 8 o'clock med or 8 o'clock vital signs to give his 10 o'clock blood pressure med. I may need a blood pressure again before I give it. So your assessment lines up with what you're going to do. Does what makes a difference in what you're going to do to the patient. All right, very good. So answer was 1 on that one. All right, we're going to look at a cognitive skill. So the last 2 times we looked at recognizing cues. So remember that was taking that data and understanding what was wrong with the patient. So we did do some recognizing cues in, let's see, did any of these have it? I was thinking about this one, but they didn't really give us an assessment. But we did know they just told us what was happening. There was a rush of air through the trauma site. So that could be an assessment. Based upon that and based upon knowing he had a penetrating chest wound, you want to recognize that cue and analyze that information and say, oh, if he got stabbed in the chest, that can lead to a pneumothorax. What do I need to do for a pneumothorax? He's in the ER. He's just getting there. What would I do for a penetrating chest wound? So when you're recognizing cues, you take the data that they give you, your assessment, and then you analyze it. And you analyze it to figure out what's happening. You're determining if the data is expected, unexpected. Is it something I need to do something about? And you're going to connect that information to the patient's clinical presentation. The next step in that process is prioritizing hypotheses. So if you remember I don't know if we were in like grade school or whatever, we were doing science projects. We didn't really do much science projects, but my kids did them, and they would have to come up with their hypothesis. I think that if I grow a plant, if I have 2 plants and one grows under a red light and one grows under a green light, the green light will grow bigger. That might have been a hypothesis or something. So your hypothesis is really, what do you think this patient's problem is going to be? or what can they be at risk for, or what is this patient's need? What do you anticipate could happen? What do you think you need to do for him throughout the day? So when they tell you your patient has COPD, you're getting a report, you're already thinking, okay, he's COPD, he's a respiratory patient, he's going to be on oxygen, I got to monitor his breathing, blah, blah, blah. So to prioritize a hypothesis, you're thinking, what is the problem? What's their concern? What is the patient's needs? And then you want to take those problems, which are all problems are within Maslow's. Then you want to prioritize. So ABC comes first. So Maslow's will help you prioritize hypothesis. Hypothesis is what you gathered from the data, and you're going to prioritize it. So using Maslow's, physical needs come first, then safety, and then psychosocial. Psychosocial is always last. If the patient's dying, I can't worry about anything else, how they're feeling. I got to worry about your heart rate, your blood pressure, your breathing. All right, so this is probably one of the hard, in fact, Saunders say it is the hardest of the types of questions. So as a nurse, we're analyzing cues because we're going to connect significant data to the client's clinical presentation. All right, and then we have to determine, is the data expected, unexpected? Now, after you analyze the cues, you got to prioritize. All right, so now we got to get to the part of analyzing the question. Analyzing questions are, or not analyzing the question, but these type of questions that say, I want you to analyze and prioritize this hypothesis, they're probably the most difficult because it's going to require you to do a few things. You got to understand the principles of the physiological response, and you have to interpret the data that they give you. So if they're telling you the heart rate's this, the blood pressure's that, you got to be able to put all that together and interpret the patient's response. What's going on with this patient? Then you have to critically think and put together your decision making skills and determine priority concerns for the patient. So that's that prioritizing hypothesis. And these types of questions can include communication, it can include documentation of the results, the process of analyzing the cues and identifying, based upon this, I identify these things as priority. So these types of questions may require examining a broad concept and breaking it down into smaller parts. All right, so can be the most difficult. Why is it difficult? You got to interpret the data. You got to critical think. You got to decision make. You got to prioritize the problem. You got to communicate it. You got to examine a broad concept, then break it down into smaller parts. You have to simulate the information, just put that information together and then apply it to the patient scenario. And that's what you're doing in your case studies. All right, so this question, most of the prioritizing hypothesis, they'll give you they call it an unfolding case study. And they'll give you maybe for each case study in the beginning, you get 3 case studies. Each one will have 6 questions. So one part of the question might be identify which problem is the priority for that patient. All right, so that could be an example. All right, so for this one, they tell us we're in home care. Home care nurse is visiting a patient. Patient has cataracts. All right. The nurse identifies which problem. So all of these are potential problems, A, B, C, and D. But which one is the priority for this patient? So she's already gathered her information and she knows patient has cataract. What am I going to do for this patient and what would be the priority problem? All right. So when we look at A, what are your thoughts on A? Concern about the loss of eyesight. Could that be priority? Why or why not? Should we eliminate it or get rid of it? Or eliminate it or keep it? That was the same thing. Eliminate it or keep it. Okay. All right. So some are saying eliminate it, not a priority. Very good. All right. Yes. Eliminate. So The key word in this, although it's focusing on his eyesight, which is the issue, cataracts, his eyesight isn't good. Um, it's a good one to get rid of because it's a concern. And when I think about a concern, although, for nurses, we're doing patient concerns. What am I concerned about on this patient? But a patient concern, or I guess I'll say a concern is something that by definition may give you anxiety or it may worry you. I think about a concern. I'm concerned. If you tell your friend, I'm concerned about you, you're worried about them. And that sounds a little bit psychosocial. So concern by definition means, from Oxford Languages, means you're worried, to worry or make anxious, relate to or be about. Like the story concerns a friend of mine. That might mean it's just about them, but to have a concern is usually to worry or be anxious. All right, so this may be just a psychosocial thing, and that's a good one to get rid of because he's just concerned about the loss of eyesight. All right, which problem are we identifying as the priority? What about B? Altered vision due to the opacity. I want to say capacity, the opacity of ocular lens. Should we keep that one or eliminate? Okay, keep it. Good. Some are saying keep, some are saying eliminate. All right. So, altered vision. The focus is on his vision. And A was kind of focusing on that, but however, it was the concern of the eyesight. B is saying that his primary problem is they have altered vision, and the altered vision is due to the opacity of the lens, which is what cataracts is, as they have an opacity of the lens and their vision is pretty blurry. All right, so yes, don't keep it. Very good. So we're gonna get rid. Let's see. Let me go back. So I'm thinking of concerning. So altered vision due to the opacity of ocular lens. If they have altered vision, which they do because they have cataracts, it's due to the opacity of the ocular lens. Um, that is a true statement, and it is their problem. It is really their problem. Now, what you want to do is between these two, if you're kind of thinking, well, both of these are eyesight, go back to Maslow's. All right, so with Maslow's hierarchy of needs, physical problems are first, safety problems are next, then psych. All right. So if I'm concerned about somebody, that is a psychosocial thing. If the patient has a concern about losing their eyesight or going blind, that's psychosocial. If you're saying the patient is having altered vision, where does that play? Is that a physical problem? Is that a safety problem, or is that psychosocial? We're going to look at D. I see some people saying maybe D is the answer. What is B? Is B physical? Is that a safety issue, or is that psychosocial? Physical. Yes, very good. That's a physical problem. So, if we're thinking this physical, based upon Maslow's hierarchy of need, that's at the top of the list in that order. This is a physiological problem. His problem is he can't see. He's got problems seeing. That's his problem. All right, so we're going to come back to that because we got to see what else do we have. Do we have any other physical problems that relate to him have this patient having cataracts? All right, let's go to D because a lot of people were saying maybe D might be the answer. D says the patient's priority problem would be loneliness. Loneliness because of decreased community immersion. Immersion just means you're, really into the community. I'm immersed in my NCLEX study, or I'm immersed in the community. I go and do outreach service or something like that. So should we keep D? Eliminate. Yes. Why eliminate D? What part of Maslow's is D? It's psychosocial. Very good. All right. So if we were thinking to keep D, we'd have to really recognize that B is not psychosocial. If I thought D was over B, then B would have to be less than that. Like maybe everything's psychosocial, and then I have to figure out another way to eliminate. But if we just look at the surface, remember patient problems, anytime the question is asking you about a patient problem, patient problems, you want to go, in order to prioritize, you want to go straight to Maslow's. There's three ways to prioritize. And those three ways are ABC, which are physical needs. That's the top physical need, because without A, B, and C, I'm not alive. The second way, go with Maslow's, which ABC is within Maslow's. It's the top physical need. And then ABC, Maslow's, or ADPI. ABC, Maslow's, or ADPI. So within Maslow's, you want to know, how do you prioritize in Maslow's? Physical, then safety, and then psych. So if they're saying the patient is lonely because, yeah, maybe they don't get out much into the community because they can't see what they're doing, then that's a psychosocial problem. The problem is loneliness. All right, so we're going to get rid of D. If you said eliminate D, good job. All right, we're down to either B or C. And we may could have even gotten down to A or B, maybe A, B, or C. What are your thoughts on C? I saw C to keep it, maybe. Good. C is safety. It is. If you're having difficulty moving around because you can't see, because you need glasses, that's a safety issue. Now this puts the patient at risk for falls. Can't see where he's going. Risk for falls, safety problem. Very good. So remember, safety is second to physiological. So we want to get rid of that, because the diagnosis of him having a cataract puts him at it does put him at a safety issue, at a safety issue of being at risk for falls. He can't see. He may feel lonely. He may have concerns. I'm scared to death. I'm going to lose my eyesight. I'm going to go blind. That's a feeling. That's a psychosocial need. So we get rid of C because that's safety. Get rid of D. D and A were both psych. B is the physical problem. That's why it's priority. All right, so it's priority because that's his physical problem. His physical problem is that he has altered vision. Why does he have altered vision? Because he's got cataracts, and they're just explaining what is a cataract. It's an opacity of the ocular lens. All right, so if you eliminated A, C, and D, that would get you down to B. So put that on your testing strategy list. Patient problems, if they're asking what's the patient's problem, what's their priority problem, three ways to prioritize. Is it an ABC problem? It's not, because it's about the eyes. So I go to Maslow's. Patient problems aren't going to be an ADPI. ADPI is for the nurse. Okay, so ADPI is for the nurse. It helps us to know what to do first: assess, diagnose, plan, intervene, and go back and evaluate. But Maslow's are where our patient problems are, and that will help you prioritize that. Very good. So the answer there was B. And so we had to understand, we had to take that data. It wasn't a lot of data. We just had to go by the cataract and think of, well, what is his priority based upon the options they gave us? What was the priority, concern, and problem? That's your hypothesis. So your hypothesis for anybody who has cataracts may be they're worried to death they're going to go blind, and they're lonely because they can't get out and see, can't get out because they don't see well. And you might be concerned that they're going to fall because they bump into things and they don't see well where they're going. But the physical problem that they can't see because of the cataracts, that is the priority, that they have altered vision. All right, awesome, awesome. So they did give us some things, ways to strategize. Just the strategic word is priority. We did use, now they say use the steps of the nursing process. That doesn't help you a lot, but you're asking yourself, it relates to planning the nursing care. Yes, I got to assess and I got to diagnose them. That's about as far as you can get. But when you're identifying the priority problem, you're using Maslow's, really. to answer the question. So the steps of nursing process just doesn't really help you. But what helps is Maslow's. Once you identify the problem, if they carried this on into a unrolling case study, then they would say, okay, how would you generate a solution to that problem? If we can fix that problem or help the patient. Physical needs are priority. All right. Very good, guys. You all did wonderful. Last few things, I'll send you your notes. If you didn't get notes from last time, let me know. We tried to send them out. Because I have a new virtual assistant, so we've been trying to send them out. But if I missed it or missed you, or one of us missed you, just let me know. This is just AdPi, just to help with what you would do when you're assessing, diagnosing, and planning. This is Maslow, so this is what we use. We went by physical needs. And physical needs could be the patient needs their medicine, they need nutrition, they need elimination. Oh, good. Yes, let me know if you didn't get notes so I can send it to you. All right, and I can go back and look at the text on here and see who all needs their notes. All right, this is some information on cataracts, opacity of the lens. That's just the description of what it is. It distorts the image projected onto the retina, and that can progress to blindness. It can get worse. These are the four basic physical changes that they can, visual changes that they can test us on. So they could test you on glaucoma, cataracts, retinal detachment, macular degeneration. Keep in mind, for any of these, when a patient is blind, no matter how that blindness is, how it's affecting their eyes, when we're looking at objects, you look at them straight on. We're not like what are those gazelles and things that have eyes on the side of their head and they can see all around. They just move their eyeballs. We're not like that. We have to see straight on. So even if I can't see something, if I'm looking at an object and it's blurry, I don't turn my head and see, can I see it this way? And see, can I see out the peripheral? You're still going to look directly. And that's just natural in our vision. So a lot of times questions will say, where would you stand at the patient? And we might think, well, they're losing their central vision or they're losing their peripheral vision. Do I stand in front or stand on the side? NCLEX still wants you to stand in front of the patient, because that's just what we'll naturally do. Even if they can hear you, they're going to turn where they hear the noise. They're not going to say, well, stand over here so I can see you and keep looking back like this. It just doesn't really, make sense. So when you're standing, you're going to look directly. Now, they might look at you and they see blurriness in the center, but maybe they can make your face out, and maybe they can't make out all the details because it's blurry, but they're still going to look at you. Some people only see shadows. It just depends on how their vision is. All right, one person that let's see, that got another free lesson. Oh wow, they may even get two free lessons. So I think initial is MC. They were the first person to register. You're the first person to register for the webinar. And it does time and date it. I think I only got it up there by the 4th or the 5th. It was a little late. I was trying to get it up there by Sunday or Monday, but I was running a little behind in the week. So they registered on December 6th that morning. I think it was like 8 something, 8:50 something in the morning, a.m. So if it went out late that night, they registered first thing that morning. So that person will also get a free lesson added on. All right, good job. So if you got correct answers on the first question, you'll get a free lesson. The one person will get that free lesson for registering first. And we'll try to make it fun. We'll think of some things. Any questions for anybody, from anyone? Any questions or comments? Anything any thoughts? All right. And you're welcome to send if there's something in that something that you would like to discuss or see included in another group study. Just let me know. If you would like to see it change date, if you think a certain day of the week is better, or if you think a certain time of day is better, just give me some feedback on that. Or if you think needing the notes, yes, making sure you get the notes. That's something we want to improve on. You're welcome. And if there's anything you want me to include, because we only have 3 more clinical skills, but we still have 5 more categories. I don't know how that happened. I guess because, well, there's only 6 clinical skills, and then there's 8 categories. So we may just do something on a case study, or do just one with just testing strategies. So very good. All right. Pain. Oh, good question. Pain is a physiological need. Pain is physiological. That's a good question. So it would fit within your basic needs. It's at the base of the pyramid. So if a question is talking about pain, like we had, I think we had a question last week that was part of the case studies for the Black Friday question. One person had pain. Pain is something that is a current problem, is happening now. All right. So a patient usually doesn't tell you, I'm in pain, but that was yesterday. If it's something happening yesterday, I can't do anything about it. We're talking about here and today. You're the nurse now, and I'm with you as your nurse today and now. Are you having pain right now? If they say no, then I don't worry about it. If they say yes, right now my headache is a 7 out of 10, then that's a current problem and I need to take care of it. Now, what can trump pain? Um, because it's part of physical needs, this is all physio. What trumps pain is A, B, and C: airway, breathing, and circulation. So if someone's not breathing good, airway, breathing, circulation, not chronic, this is something acute. It would have to be an acute ABC problem, then that would oversee pain, because all of it is happening now. So I got to figure out, okay, he's in pain. This one's heart rate's up, blood pressure's this, but this one down here can't breathe. I got to go see the patient who can't breathe. Maybe their secretions, they need to be suctioned or something. I got to go see that one first. So ABC, acute. But if it's a COPD problem and he's wheezing because he got up to the bathroom, and he always wheezes when he gets up to the bathroom because he's exerted himself, I probably can put him on the back burner because that's COPD. Unless they tell you they're having a issue, like their SATs is not what they normally are. Their something is different. So if a patient has hypertension, that doesn't tell me anything. Although hypertension is part of circulation, your circulation is your heart rate and your blood pressure, your cardiac output. Hypertension doesn't tell me, do you have hypertension right now? What is your blood pressure? I got to know more information. If their blood pressure isn't high currently at the moment, then pain still comes over that, and it is part of physical. Yeah. And I think there are some texts, I've read some texts where they say, well, pain could be psychosocial. That just depends. I mean, unless pain is like they're having a mental, like a conversion disorder. I'm hurting all over, I'm hurting somewhere, but there's really not a physical need for their pain. It could be psychosocial. But according to Maslow's, it's a part of your basic needs, because if I'm in pain, I don't want to get up, I can't move, I'm not going to be mobile. It's hard to cough and deep breathe. Pain affects physical problems, physical needs, and it does affect the patient psychosocially. So I think that's where it gets confusing, because pain affects the psyche. Yeah, but that's a very good question. All right, so we love coming on Saturday. We'll keep it Saturday. Very good. Well, thank you all for coming. If no other questions or concerns, I don't think I had anybody new tonight, but you all have a wonderful evening. I'll see you next Saturday. I'll see some of you tomorrow and Monday and throughout the week. So if you haven't scheduled your lesson, go on and schedule. You have a good evening. Good night. Thank you.